Welcome to Season 2 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, I'm speaking with Dr. Lisa Maragkakis, the Director of Infection Prevention at the Johns Hopkins Health System. You may remember her first podcast interview with us in the early days of March, when Dr. Maragkakis explained calmly how Johns Hopkins was preparing for COVID-19. We talk about the hospital's experience since then and what lies ahead with a new season of flu and other respiratory viruses here again. Let's listen. Dr. Maragkakis, thank you so much for joining me again. And I say again because you were one of the very first guests we had on the podcast 6 months ago. People who are listening can find that on the podcast website. But at that time, we didn't know what was going to hit Baltimore, how many patients would be coming to Johns Hopkins, and you were responsible for infection control at the hospital.
Well, thank you so much for having me. And you're right. This has been quite a journey, a real challenge for everyone, of course, but particularly in the hospital and healthcare. I'm pleased to say that everyone has really pulled together. So grateful to all of my colleagues for the response to this situation and really to the broader community. So many people have come out in support of our efforts, and we're very grateful.
Now, after a very intense period of a lot of patients reorganizing the clinical service, things have calmed down with respect to the pandemic. There's still a number of patients, but it's not quite as many as before. What are the challenges that you're facing as you're overseeing this effort at Johns Hopkins now?
Well, we're very fortunate in the Baltimore, Washington area that the numbers have improved substantially. We are remaining vigilant because the data, the metrics that we follow, including cases per 100,000 and the percent positivity and the number of hospitalizations for COVID-19 are all in much better territory, but they have plateaued at a level that is higher than we would wish. And we are heading into the respiratory virus season. So I guess I would say that we have ongoing challenges around supply chain, remarkably, that we still need to really conserve personal protective equipment, and laboratory reagents require a lot of strategic planning and multiple platforms to make sure that we can provide the testing. And so a lot of the same themes and challenges are still there. They have not largely been solved at a national level. And then, I think the other challenge that I would mention is what is being termed pandemic fatigue. So really the sense that people are realizing that this is a marathon, not a sprint, that we are going to have to sustain all of the efforts over a very long period of time. And that's a challenge. It's taking a toll on everyone. Mental health and self-care are so important.
How do you see that in the staff at the hospital, the fatigue?
Well, I see a yearning for getting back to normal. And, we see this in healthcare as well as in the community, a desire to get back to the way that things used to be, particularly, I think, around social interactions, that everyone is missing those types of social connections. So we're being careful.
Right. Even at work in the hospital, because it used to be, a lot of engagement. People would eat together, people would share their lives, the staff that you're working with, and now it's got to be a lot harder.
Absolutely. In that regard, we're fortunate because we do see our colleagues in the workplace and are not working remotely and dealing with the isolation that many are across the country. But at the same time, it is not normal. And we do have to maintain that physical distance. And we see some episodes of transmission of the virus, particularly around break rooms and social gatherings for eating when masks are removed. So it's difficult to keep up those efforts over the long haul.
Now, you mentioned respiratory virus season. Tell me a little bit more about what's concerning you as we head into the fall.
Sure. So with the respiratory virus season coming, we know that predictably every year influenza, respiratory syncytial virus, parainfluenza, and others return, and this year will likely be no different. And that presents several challenges. First of all, with a regard to healthcare capacity, obviously that has been a challenge for taking care of patients who have COVID-19, and we are concerned about a resurgence of COVID-19 colliding with an influx of patients with other respiratory viruses that happens each fall and winter. And so, that really complicates surge planning. But in addition, we're worried about patients, our patients and members of the community, recognizing that there will be additional threats to their health, the possibility of co-infection. And then the diagnostic uncertainty that is going to happen. We have been in a time, as awful as it has been, where it's pretty clear that if you have a fever and or respiratory symptoms, it's COVID-19 until proven otherwise. And that will go out the door as soon as all these other viruses reappear.
So there's a clinical question of how to evaluate patients. And then there's the potential surge in patients.
Exactly. And the infection control considerations around bringing in patients for evaluation under those circumstances.
So there's some people who are quite optimistic, and they say there hasn't been a lot of influenza in the Southern Hemisphere, that all this staying at home and mask wearing is going to dramatically cut down on the co-infections and the number of other respiratory viruses. Do you agree with that? Do you think that's possible?
I think that's right. I think that's entirely possible, and it shows us what we can achieve if we can sustain our infection prevention interventions, the very basics of hand hygiene, wearing a mask, maintaining physical distancing. What's going to be much more difficult, of course, is using the outdoors as one of those measures. As the weather gets cold, we come inside, and people will be, as we are every year, thrust into closer contact with each other. So that is definitely going to be a challenge.
Now, you mentioned diagnostic testing. I just want to ask you this. Do we have adequate diagnostic tests so that if somebody, say, is febrile, has a fever, and is coughing, that you could test for a bunch of things at once? Or do you think that capacity still needs to be developed?
So that is a great question. And we anticipate having, just within the next several weeks, access to combined tests that would really be the ideal, so that a patient who presents with respiratory symptoms or fever would be able to have one sample obtained for testing for a variety of viruses, most notably the SARS-CoV-2 virus and influenza, to sort those two out at least. And we do think we will have those combined platforms. I am just hesitating a little bit because we have seen such shortages of lab reagents and testing kits. So I think I'll believe it when I see it. But that is the plan right now, is to have combined testing platforms.
Got it. And let's talk about the flu vaccine. How important is it for people to get the flu vaccine this year?
Well, the flu vaccine is important every year, but this year more than ever. For the reasons that we've discussed, it will be very difficult for the healthcare facilities, the diagnostic clinical decisions, and for patients themselves to sort out what is going on and what they need to do to take care of themselves and to protect their loved ones and their community from transmission. So, as you said, the same measures that we've been talking about will work for both viruses, for all kinds of respiratory viruses. So that's the good news. But, I think the more complicated news is that we need to get the flu shot. Everyone over the age of 6 months should get the flu shot. And then also seek care when you get symptoms during this respiratory virus season. Whereas in past years, you might have stayed at home and just tried to see how it goes. And if you feel better, I think it really is worth getting a diagnostic test so that you can take the right steps.
Right, because if it turns out to be COVID, you really may need to isolate yourself from others in a
Right,
particular.
including those in your own home.
Yeah. Now, this year, there's a new rule at Johns Hopkins about the flu shot, I believe.
There is. So we have always, well, for many years, required the flu vaccine for all of our employees who are in our clinical buildings. So anyone essentially who would come in contact with any of our patients, even riding in the elevator with them or any type of contact, would be required each flu season to get the flu vaccination. But previously, the members of the university and those who worked in non-clinical buildings were not required. They were offered the vaccine, but not required. And this year, everyone is included under that mandatory vaccination umbrella. So that is a change, and it really is expanding our purpose, which has always been patient safety focused, but now really is also for the safety of our employees and their families.
And so tell me the rationale for that. Is it to reduce flu as well as reduce kind of COVID scares? What's the thinking?
I think it's both. Definitely the main purpose of the flu vaccine is to prevent flu and to save the healthcare consequences, medical consequences for those who are vaccinated. But it has the benefit to the healthcare system, delivery system as well, of reducing the types of diagnostic dilemmas and patient surges that we've discussed. And then as an employer, of course, it also has a benefit if your employees are not out sick.
Right. I mean, there's a lot of talk about how much more lethal COVID is than flu, but flu can be lethal. It's not a common cold.
Absolutely. And I know there is a general misconception among many people that the flu is used as a kind of general term for any sort of respiratory infection. And what we know is many respiratory infections are on the mild side, the common cold, et cetera. And so people need to know that that is not the flu. And while there's a range of severity of symptoms for influenza, as you say, it kills many people, tens of thousands of people in this country every year.
Now, just to get rid of one misconception, some people are wondering whether if they get the flu vaccine, they couldn't get a COVID vaccine or there could be some issue. And I'm not aware of any evidence or concern about that. Are you?
I'm not aware of any concern about that either. I don't think anyone should delay or miss getting an influenza vaccination due to any concerns about what might come later in terms of a COVID-19 vaccine. First of all, we don't have one yet. Those trials are ongoing, but we do have a lot of experience with influenza vaccine. And it's the best way to protect ourselves against influenza. It's not perfect, and we know that, and it varies. The efficacy varies year to year, but even if you do get influenza after the vaccine, it tends to lessen the severity of symptoms of illness and shorten the duration. So it's definitely worth doing.
Really can reduce the chance you have to go into the hospital, for example. Last question, and I'm curious what you think about this. It seems like the places that can maintain their vigilance can wear masks, wash their hands, keep a distance as possible. It sounds like what you're saying is they're going to have not only less COVID, but less flu, less paraflu, less other viruses, and it'll be a bit of a virtuous circle. On the other hand, places that lose their vigilance may have more COVID, but then they may also get more flu, which could, get more people sick, more people in the hospital, other viruses. They could have a much worse time, kind of like a vicious circle. And I wonder whether we're going to start to see some places doing kind of much better on everything and some places doing much worse. It'll be sort of like two kind of clumps of places as if we were to look at the distribution. Do you think that's possible?
I think that's a very accurate description of what is likely to happen. And so we are really at a decision point. We are at a fork in the road where we can choose to continue and persevere through the coming months, weeks and months with the kinds of interventions that we have put in place for COVID-19, and that will put us in very good stead for all the other respiratory viruses, as you say. Or we can choose the other road and look at some of the favorable data and decide that we can relax and be less vigilant and try to get back to normal. And if we do that too quickly, I think it's going to be a feedback loop and we will have more COVID-19 but we will also have influenza in those communities. So it is concern. It's where the intersection occurs with the pandemic fatigue that we discussed. And I think we're very vulnerable right now as the data look better, but not great in some places.
Yeah, we're really at this sort of branch point. Well, I really appreciate your joining me. I remember speaking in March primarily because I remember walking out of your office. We actually did that interview in person and feeling reassured that there was somebody who was staring this problem right in the face and knew what to do. And that gave me a lot of comfort for the weeks that came. And it has all been proven true given how well the clinical center and others have handled this under your leadership. So I really want to thank you for everything that you've done, Dr. Maragakis, and thanks for joining me again.
Thank you for having me. Infection prevention works, so there is an optimistic message. We can get through this.
Public Health On Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Lamari Morales. Audio production by Spencer Greer, Niall Owen McCusker, Cian Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Thank you for listening.